The following podcast was recorded at the ANZICS Safety and Quality Conference, July 2014, Rapid Response Teams. Peter Hicks asks, is there a need for a rapid response database in Australia and New Zealand?
Here today with some expertise in registries, with my long-standing role with the ANZICS core group and the other bunch of colleagues that helped me with that. So what I want to do is to talk a bit about what a registry is, what a registry does, and how rapid response teams may have what difficulties there might be with a registry for a rapid response team. Now, for a large number of the audience here, you won't know much about the ANZICS registry activities, and another bunch of the audience will know quite a lot about it, so I apologise if some of this sounds a bit familiar. Now, the main question we want to ask ourselves is, are we doing this right? And you can guess for yourself with that one. Are we doing this right? Are we doing this well? Are we doing this safely, efficiently, and can we do it better? And these are the questions that we would want a registry to look at. So what is a registry? Well, a registry, if you look up the definition of it, it's a list of things, and it started with a registry of ships and births and deaths and marriages and things like that. So really it's a collection of information, and the collection of information is actually the database part. So when everyone talks about databases, what they really mean is a registry. So from the databases of information, you make reports, and then within those reports, or around those reports, there are processes. There are processes for collecting the information, processes for distributing the information, and as I'll come to later, more importantly, processes around what happens if the data isn't good for any particular unit or staff member or place. And lastly, there's research. This is when you don't quite know what the question you want to ask is, but you collect a whole lot of information and then you go around and ask it afterwards. But in summary, a registry is a quality activity, and that's probably the best way to think about it. There's a number of them around in Australia and New Zealand, and ANZICS Core, which I'll talk a bit more about in a slide or two, and the dialysis and transplant registries are probably two of the oldest and largest and, I was going to say most, competent, but what I really mean is thorough in the way they've been done. But the core one I'll talk about later. So transplants and dialysis are treatments, cardiothoracic surgery is a treatment, major trauma is a disease, and that has a few complications because identifying major trauma patients isn't easy. You've either got to be severely injured when you hit ED or die later or go to ICU later, so it's not quite clear what those patients are. Massive transfusion registries are a little more straightforward as long as you can define what a massive transfusion is. There's a large number of cancer registries, which are a disease registry, haemophilia is a disease, and so forth. Now, all the registries have similar stages to them. Firstly, identify what it is you want to collect information about, be it the disease, a type of patient, a process. Collect the information somehow, electronically, on paper, at the time, retrospectively. Send it somewhere. The line in the middle then represents the bit in the middle. So somebody collects the information, cleans it, makes sure it's accurate, goes back and asks questions, validates it. When they're all good with that, then you write your reports, get the information out, and you distribute that back to the people who sent you the information in the first place. But also in the middle, a group of people look at the information to go, well, what does this look like, either nationally, at a state level or individually, and is there anybody in the middle of all this who we think possibly isn't doing as good a job as they could be? You give the reports back to the people who sent the information, and then their job is to go through the information themselves and say, how do we compare? Now, ANZICS has 3 registries. There's the adult patient database, which collects information about individual patient admissions to intensive care, and it's got over 1 million patients in it, and it's probably the one that's most of you are more familiar with. And I was interested to see that actually Rob Hicks, who's in the audience, was actually the pioneer. Sounds better than grandfather, doesn't it, of the APD. We have the Critical Care Resources Registry. This is the annual survey of information about your intensive care units, how many beds, how many staff, how much activity. Again, pioneered by Graham Hartz, who's also in the audience down there. And we have an equivalent paediatric registry which collects, sort of like the adult patient database thing, information about paediatric admissions to paediatric intensive care units and non-paediatric intensive care units, care of Tony Slater, who's also in the audience. I think it's quite impressive that they're all here for this important topic. Now, what do we do with that information? Well, you can try and compare it against a standard. You pick something and you say this is the number or the size or the shape, and we're going to compare your unit against that. It's often very hard to find a standard to compare something against. It's actually more useful to compare your unit against all the other units to see how you rate, partly because we know that standards change over time. So what can we compare? We can compare mortality rates, actually the raw percentage, which isn't much use. We can compare the ratio of observed to expected deaths, that's the SMR that people have mentioned, but we want to compare that against all the other similar units in your country or state. We can compare things like after-hours discharges, cancelled surgery, readmissions, how well-resourced you are, clinical bits like your use of DVT prophylaxis, central line-associated infections. And again, I'll just emphasise the comparing between units part. So what we do is we hand out these reports to units and we provide how the other units look, their information, but in an unnamed, or I find it hard to spell anonymised, so I put unnamed in there. But essentially you want to know where you sit. Now we also provide information to the states and territories so that New South Wales knows that the quality of intensive care in their state is good, there aren't any bad outliers, and that it looks as good as Victoria. So the government has the assurance that intensive care is being provided well in Australia and New Zealand. The important part though is what do we do if we find a unit that's not performing well? The Bundaberg type example, or what other examples you know of, the Bristols. What do we do? Whose role is it to identify that and then ask somebody about it and then analyse it and manage it? And ANZICS has actually got quite a detailed policy and procedure for doing this, because this is the hairy, scary part. What responsibility do we have as owners or guardians of that information if we find something that's not right? It's not our responsibility to fix it, but we have a responsibility with it. So bear that in mind when we start talking about rapid response team registries. Who's going to provide the governance? So this is an example of probably the most useful report that ANZICS Core does. And this is called a funnel plot because it sort of looks like a funnel lying on its side. And the big red dot's Wellington Hospital. And the bit across the bottom is the number of our admissions, and the bit up the side is our standardised mortality ratio. Now, it doesn't actually matter what that number is. What that tells me is that Wellington sits in the middle of all the other tertiary units. Now, allowing for whether you believe the sort of statistics or not, that tells me that our unit is operating averagely as well as the other tertiary units. Usually we're a bit further down, and I can say we're operating better than most of the other tertiary units, and we're certainly not over the top. There's one little, there's one little, if I can find the little thing up the top there, up the top here, just sneaking over the top of the line, and it's bordering on being an outlier. That's 2 standard deviations away from the average of the group. And it's this type of information that's valuable because we know that ICU mortality has been decreasing with time, and that doesn't matter because all the units should be having a decreased mortality as well. And I think this is a sort of information we would like to have about rapid response teams, but there are some difficulties. As the previous 2 speakers have said, how do we assess the teams to know what information to measure so we can do this sort of performance charting? And the way we've tended to try and categorise this is by dividing it into structure, function and outcome, fake or otherwise. So the structure part's important, and this is a bit like the ANZICS survey registry. How is your rapid response team set up? Who's in it? Who owns it? Where does it live? Who pays for it? What early warning score system do you have? What's your activation levels if you have a warning score? And what's the response system? And previous speakers have alluded to the difficulty of comparing all that. Functioning. So this is sort of counting stuff. How many calls do you have? What sort of calls are they? What sort of patients are they? What time of day was it? And then there's a few sort of quality parts about the functioning. Did the patients have their observations done in a timely manner? Was the early warning score calculated every time an observation was done? And I've put up here outcome, but this top one actually should be back in the following thing. How did the activation response thing work? And the previous speakers have explained some of the measures you can do with that. And then you get to outcomes. So what was the outcome of that call for that patient at that time? And again, I think, Rick did a good example of the things that you can look at, as did Imogen. What happened to the patient later? So did the patient get to die or go home or go to ICU or go to rehab? How many calls did the patient have? And it's different from what was the outcome of the call per se. And there are other things that you could look at as the outcome which the previous speakers have mentioned. Now, there are quite a lot of difficulties with a rapid response team registry, which to some extent explains why it hasn't happened easily at the moment. Now, the rapid response team response is actually pretty easy to identify. Something happens, a phone call gets made, people turn up. It's pretty easy to spot it. The difficulty is most of our existing IT systems don't tell us that it's happened. Our patient management systems don't tell us. Various other clinical systems that you have, laboratory stuff, radiology stuff, discharge summaries, don't capture that information. Now, most of us have got logs with the telephone operators or an interested person or somebody who's trying to log this stuff. It doesn't exist within your existing IT standard stuff. Most of the data you want to collect, you've got to collect at the time, and it's quite hard to do it retrospectively. As in, why did we turn up? What was wrong with the patient? Some of that will be in the clinical notes if you pull them out a day or two later. Not a lot, I suspect. And a lot of the timing won't be. So our existing IT systems won't help us capture that. Say compared to cardiothoracic surgery, you can pull the bulk of that information out of your theatre system, IT patient system, lab system and stuff like that. There may be lots of data, lots depends upon what sort of registries you're used to dealing with. There's a reasonable amount that you need to collect, and that all takes time to do, as I'm sure the nurses who do the bulk of the data collection will tell you. And the other point that someone's made is structuring these events is not straightforward. So one cardiac surgery operation is one cardiac surgery operation, and you might come back later and have another one. But patients have multiple calls. So a single patient might have 5 calls in this course of a 2-week stay. Now, are all 5 of those calls related to the one event, as in their pneumonia, or did they have a pneumonia this week and then a PE the next week, and they had 3 calls about that? So there's quite a bit of structural difficulty in designing the data systems and the databases to go with that. Now, as everybody has pointed out, not all responses are the same. So when you saw that funnel plot I did, that was tertiary ICUs. Now, if we put all the ICUs in that funnel plot, the little ones that have got no resident medical staff and the big ones with thousands, is that a fair comparison? How are we going to accommodate or adjust for the differences in whether this is a nurse-led only, whether this is a primary team responsible thing, or whether this is ICUs taking over the hospital approach? So the benchmarking is going to be extraordinarily difficult if we don't know how to adjust for that. And I think, as the previous 2 speakers have explained, outcomes that nobody has really given me a good set of numbers or things that we can count or measure to go, here's the one thing we want to use to compare. So as John eloquently pointed out, your dose rate will depend on how you define patient admissions. Death is not a very good outcome measure for this particular group of patients. By definition, anyone dying is going to go through at some point in their dying process an early warning score that's going to trigger a MET call, unless they arrest suddenly, in which case they've skipped the whole lot. So we are, by our definition, identifying patients who are going to die. So guess what? They die. So how would we adjust for all that? And maybe it's not the fact that you die, but how you die that's important, and have a quality of how you die. Do you get CPR when you're dying when you shouldn't? That comes into the outcome measures with all this. So this is even without thinking about the patient experience stuff, which I have to agree with Imogen's a really fantastic quality measure, if only we knew how to count it, because we like counting things. The other thing is governance, and one of the points of this meeting is who professionally owns rapid response team stuff. Now, because this is an intensive care society and we advertise through intensive care mailing lists, guess what? We've got a whole lot of intensive care people here. Would the physicians want to be interested in this? Would paediatricians want to be interested in it, or obstetricians? So when we get round to the what do we do with the hospital that doesn't seem to have very good outcomes for their patients, who's the professional group that's going to sort of provide the governance and safety, if you like, of the information to do this? And I guess ANZICS is sort of putting its hand up at the point here to say we think we have a role in this. But one of the lessons we've learnt from the adult patient database and paediatric stuff is the people giving you the data have really got to trust you that you will behave nicely with it, which means you don't publish papers identifying outlying units with their names all over it. You do that and you don't get any more data. So I guess this is the sort of the elephant in the room bit. Who's professionally responsible and who's going to take the lead in providing the governance and confidence? Registries are expensive, and that's another reason why it hasn't happened yet. So ANZICS Core's got between 7 or 8 people, depending on what we're doing. Costs about $1 million a year to run. It is subsidised and underwritten by ANZICS. We provide free, in inverted commas, software to all the units to collect the information, but it's not free for ANZICS to make it and maintain it. And there are between 120 and 160 units that collect information, some of which have paid data collectors, some of which have unpaid data collectors. ANZICS doesn't pay any of the data collectors. The hospitals have to pay for that themselves. There are research questions that we would love to have the information to do. What's the ideal early warning score? I think as Alex Seretti's pointed out, in the UK there's this enormous big database of stuff and they can tell you the specificity of each thing. What's the ideal activation threshold for a hospital of your size? And the questions are fairly straightforward. And so this is really justifying why we need to have the registry, but really that's a bit of a non sequitur. Everybody knows we need to have it. This is just sort of the benefit you might get out of it. So in summary, a registry will measure and monitor quality. That's what it's for. The data is going to be hard to collect for rapid response team. The systems of providing the response are complex, not easily compared, and vary widely. There's quite a few database structural issues with how you put the data together. The quality measures, while talked about, are still fairly unclear, and nobody can tell me the 3 or 4 things that really represent the quality of what you do. It's going to be expensive and time-consuming, but there is no doubt that it's absolutely necessary. My one last comment is really that not all rapid responses are appreciated. Thank you very much.
For more podcasts from ANZICS, go to anzics.com.au.